Okay, I will get started because my first few slides are introductory a little bit, so people can join while I just give you a general introduction. My name is Aniko Szabo. I'm from the Division of Biostatistics at MCW, but I'm here representing the CTSI BERD group, the Biostatistics Epidemiology and Research Design group. And I'm going to be talking about case control studies. In general, I will try to pay attention if somebody raises their hand. I'm not guaranteeing that I'll notice it. So feel free to unmute yourself and chime in if you have an urgent question, and hopefully we'll have some time for questions at the end. So first I want to introduce a little bit about our CTSI, who is sponsoring this presentation. So the BERD is, again, it's our biostatistics group within CTSI. Our group is directed by Dr. Spencer Huang from UWM, and we provide statistical support to CTSI investigators, and it's provided through 3 groups: the Biostatistics Division at UWM, the Biostatistics Consulting Service at MCW, and that's actually I'm a director of, so that's where I'm located, and also the Center for Advancing Population Science, CAPS, within the Department of Medicine is also involved. The support is mostly provided through mini grants, and that what mini grant, it's somewhat a misleading name because it's not really a grant that you have to really compete for. So there are lots of mini grants available. So they provide 4 to 6 hour support, and the goal is really to help you with some advice that can be done with 4 to 6 hours. So not really data analysis, but things like discussing a study design, data analysis plan, do some sample size calculation, maybe some preliminary data analysis related to study design, review analysis, discuss findings by others, but we have really not much time for actual big data analysis. On the other hand, I think it's a really good mechanism for getting support while you're planning your study. And or if there's anything you need to talk with a statistician. And you can apply on the CTSI website. There's a link for these mini grants. And again, they're essentially automatically approved as long as it's, sounds anything remotely related to statistics you would want to talk to us about. But if you need more, for example, the Biostatistical Consulting Service definitely provides lots of assistance beyond what the BERD mini grants. Anything. We can also help with study design, but also with actual data analysis, data management, clinical trials, whatever you need help statistical, we can do it probably. And if not, we'll let you know. In general speaking, it is fee for service, and there are your rates for MCW customers. Outside clients have higher rates, but it depends exactly who they are. And there's also a big group of people who can access us, and I hope if you belong to them, you know about this. We have integration contracts with some departments like surgery, orthopedic surgery, PM&R, freighted pharmacy, and some divisions within departments like hematology, oncology within medicine, or pediatric emergency medicine. So their investigators their department or division pays for our help to them. And this one can apply through iLab. Or if you have any questions about that, you can email our email address. Okay, so that was kind of like a brief introduction, so like to the whole BERD and where to get statistical support a little bit. So now to our actual talk today. And so what I plan to do is to talk a little bit about study designs for risk factor evaluation, introduce the basic concepts of case control studies, discuss some issues such as confounding and matching, which are really important in case control studies, and then give you some examples of how these concepts apply to two specific case control studies that I've been involved here at MCW. And in general, I will be focusing on when discussing alternatives or other designs in retrospective design, because case control studies are retrospective designs. Certainly there are prospective designs that one could do. And mostly actually in cases where the data is already kind of out there, like in charts or something like that, and not newly collected, though we'll touch on some potential data collection things. So the motivation, as I mentioned, kind of implied already for case control study, is if you want to identify risk factors. That's the setting in which you would use them. And I want to start with a common proposal that I've seen coming to our consulting service. So people approaching me that some investigators said that I want to study some bad outcome event X. And I will collect data on all cases of X in the past 10 years, because it's not very common, so I can go back. I need to go back and collect this. I can do chart review, collect information on that. Then I'll find out what's the incidence and find its risk factors. And this is, I think many of you will, if you think about it, this is not it doesn't quite work, this idea. But I think it comes from a very logical place. And so why would somebody think that you could study risk factors using this way? And I think about it, it's like the food poisoning model. So imagine there is an outbreak of food poisoning, and the health department or the CDC or whoever comes out and wants to study, well, what are the risk factors, right, for this event? What causes this food poisoning? And what do? Well, they find people who were affected, right? Find out what they ate, where they ate, whatever. And then once they find something, oh, everybody ate the same thing, that must have been the cause, right? So the commonalities will identify the likely source of the pathogen. And I'm sure this is kind of not quite correct exactly what happens, but I think this is like a general idea of what would be happening in this case. And this would work because, or if there is a single cause or source. So like once you zoom in, there is actually a causal factor, like overridingly what caused this food poisoning cases. It also kind of requires some knowledge about food frequency or what people's behavior in general. So if you find that 80% of the victims ate lettuce, you might not raise your eyebrow, but if 80% ate dragon fruit, which is my stand-in for something people don't eat probably a lot, then that suddenly, oh, that must be it, right? But you only can tell the difference because you know something about what's common, what's rare, right? So you have some idea what to expect if something is not causative. And of course, this is also not the end of the, even then when they identify something like that, this is not the end of the story. They'll do further work to establish the link, right? So it's not like that they'll stop and say, oh, then that's it. But this model, again, I think this is kind of, I think that's what investigators are expecting when they say that, well, I'll just look at cases. They think that they look at it and then suddenly there will be an aha moment where they see, oh, all of them share this feature, that must be a major risk factor. And if there's actually some really major risk factor, maybe it will work. But in general, it does not work well in most settings. So in studies in general would need controls, right? So that's what was missing in that proposal, is that there were no people who did not have condition X. So we would need similar studies who could have had this bad event X to happen, but they did not, right? So to figure out what is typical and what's not typical. So for as an example, I want to start with a study I worked with Dr. Dave Lal from pediatric surgery. And he's studying esophageal atresia. And I hope I'm pronouncing it correctly. So this is a birth defect. in which the upper and the lower parts of the esophagus do not connect. On this picture, I hope you can see, right? It kind of ends here and doesn't connect to go to the stomach. This usually is diagnosed at birth or maybe shortly before. It is repaired surgically after birth, but there can be complications to this afterwards. And one of them is, for example, esophageal stricture, when the esophagus gets thinner again and the baby cannot swallow this food well. So the research question they wanted to address is the incidence and specifically the risk factors of this esophageal strictures after surgical repair. So how does this get built up to make an actual study? We start with a hypothesis, and that was that surgical management choices affect the risk of adverse outcomes and the stricture. Then define the population. Well, they defined it with specific type C EA, surgery repaired at age less than or equal to 6 months. So you have to be somewhat specific, right? And then they find a cohort of patients who we would be looking at. And they actually looked at 11 institutions who contributed data within a certain time period. And this was a retrospective cohort because the studies was actually conducted somewhere in 2015. So it was after it was all happened, right? And then they went out and collected baseline and outcome information from the chart review, right? So all things about the babies and the surgeries and what happened and whether they had stricture and so on. And after that, they were able to evaluate incidence of all kinds of things, bad things that could happen, mortality, the stricture specifically, which is pretty common, 43% of babies had one within a year, anastomotic leak, other complications, and then ran statistical analysis of the risk factors, which was actually logistic regression, adjusting for confounders, and they found some risk factor for mortality. They found some risk factors for stricture, which is kind of the most interesting they're studying. Risk factor for anastomotic leaks, and some of them are indeed risk factors that are surgical choices, like they place a transanastomotic tube, or there's some prosthetic material, and some are not really, like congenital heart disease is clearly not a surgical choice. So this is a very nice study, studying risk factors of the bad outcome that they were interested in, right? But I want to note that this is most definitely not a case control study, right? But the reason I wanted to go, and actually, right, my title even says there, it's a retrospective cohort study specifically, because we had defined a cohort retrospectively and then followed those patients and looked at their outcome. But the reason I wanted to go through it is because this is a really good study design to study risk factors. In fact, I think, actually very often that this is what you want to do. And I like to think about case control studies as what you would fall back when there is some reason that this doesn't quite work out this way. And so we'll go through some examples and why would that happen. But even then, I think thinking through this as trying to design a retrospective cohort study and then kind of switching along the way to a case control is a very good idea when you're looking at risk factors. So my next example will actually be a case control study, I promise. So this was a study of COVID risk factors in breast cancer that we did like 2 years ago with Dr. Chaudhary and Zurko from hematology oncology. So we started designing it in summer 2020. So when COVID was just relatively new. So the hypothesis that they wanted to study was that there are some cancer-specific risk factors for COVID infection in breast cancer patients. So Dr. Chaudhary is a breast cancer physician. And so that was kind of what they wanted to study. What are the breast cancer-specific or breast cancer-specific risk factors for COVID infection? So the population would be adults living with breast cancer during the COVID pandemic in 2020. That will be within our time frame. And the cohort of patients we would be looking at is, well, we're going to do the study at Freighter and MCW, so maybe patients followed at the clinics. Though it's already, I have there a little question marks because it's kind of a little bit difficult to operationalize. Who, what are who are the patients who are actually followed? Could we actually go out and recruit them? Like in the previous, in the example with the babies, you could actually go out and at every time there is a surgery, you could have prospectively collected them. Like if you were a time traveler, you could approach those babies and ask their parents whether they want to be in the study, right? So it's kind of a, you could have then here it's a little bit trickier, but probably it's possible if you're careful. Okay, and then we would need to so once if we define the cohort, we need to collect the additional information, right? And specifically cancer-specific information and COVID-specific information in terms of risk factors. Well, actually, I think the cancer-specific information would be the real problem. So that is not readily available. You would really need to have to go back and do a chart review. And there were major questions like, can we reasonably review that many charts and actually collect the data of the cancer information about so many patients, of all the patients who are being followed at MCW clinics. So that is getting a little bit much. So we started thinking then, okay, maybe we should be doing another study. So in general, so there are some reasons for not doing a retrospective cohort study. So one is if actually defining an operationalizable cohort is difficult. So you can't quite define who actually belongs to your cohort. You can have an idea about the population, but if you have trouble saying who is in the cohort and who is not, because you might not have access to their data, right? So here I'm talking about is that it's in hospital, but if they are not in, everybody's in hospital, then, or at the clinics, you might even have difficulty very well defining who it is. The other issue can be is that the power of the retrospective cohort studies is driven by the number of events. And if you have a rare disease, and COVID maybe was somewhat rare back then, a rare outcome, then you need a large cohort to have enough events, right? And that's not a problem per se, we can process that. But what happens is that most data is about subjects without an event. Again, this is still not an issue unless the collection of the covariates is expensive. And by expensive, I mean that it might just take a lot of time. Like if you need to chart review 1,000 patients, that might be a problem, and then it might not be feasible. But it might actually be expensive in terms of money, more directly, if you have to go back and run, some kind of a test on some samples to actually collect new data, right? So again, I said mostly it's about existing data, but still there could be that there is new data that you need to collect, right? Or you can go out to interview people or whatever. So if you're interviewing lots of cases and they contribute very little to the power, that's a lot of wasteful effort and makes the whole study infeasible. So this is another case where retrospective cohort studies are problematic if you have a rare event and you have expensive data collection along the way. Because if the data is just available out there, it might not be a problem that it's a big cohort. Well, we have computers, they don't care. But the third issue could be, and we'll see examples of that later, is if the confounder adjustment can be complicated, then sometimes it's a case control study can help with that. And I'll get back to that later. So having talked about them so much, so what is a case control study? So it is a retrospective observational study aimed to determine if there is an association between risk factors and an outcome of interest. Okay, so it's definitely always a study of risk factors. But the key feature is that the data collection reverses the causal process. So it's kind of like doubly retrospective. So you select participant into the study based on the outcome, based on whether they had the event or they didn't have the event. So had COVID, didn't have COVID, had atresia, not stricture, or didn't have stricture. That's the outcome. And then you collect prior risk information before the outcome once the outcome is known, right? So it's not only just you are looking back potentially in the past, but you are actually, again, collecting the outcome which actually came later, and then you're looking back what were the risk factors before. So again, you identify the cases and then find controls based on the outcomes who didn't have the event. So the idea for the controls is that they should come from the same population as the cases, right? They should be at risk. So they could potentially have had this event X, but they did not actually have an event X, right? But again, the definition is very much based on the outcome. And that's what makes them kind of inverted and sometimes confusing, is that inclusion criteria are based on the outcome, which is in general is a big no-no. You have to be very careful about doing that, but case control studies are designed to do that. So going back to our COVID, so how do we do example is how do we do it as a case control study? So first we define the cases, which is very easy because so this would be breast cancer patients at the Freighter and MCW clinics who diagnosed with COVID, and we had a specific time frame, March to December 2020. And then we would want to have controls. So they would have to be followed at the clinic during this time, right? So what does it mean being followed? Because so we actually said that these were patients who were actually seen at least once in the clinic from January to July. So that's how we defined who is actually kind of followed. Because the problem is that maybe we want to know that if they had COVID, we would have known about it, right? That's the critical issue here. So, and then many information was readily obtainable from EPIC, but some additional information had to be collected from chart review, and that's the cancer specific. So stage, hormone receptor status, treatment history, whatever other things we could think as potential risk factors that they were interested in. But we also have to think about that, you know, whatever is the cancer information is probably not the major driver of COVID risk, right? The major driver of COVID risk is actually, it's an infectious disease, right? So it's actually like being exposed to COVID, right? So we really want to capture whatever, all those potential confounding factors, like the major drivers. And at that time, you know, we had some idea like age, older people were, minorities were more likely to be exposed, but certainly we felt like the place of residence, so a place where COVID is spreading, if somebody lives there, that's where you would expect a higher risk of COVID. So now all of these were at least within Wisconsin, right? They were temporary at the same time. So at least in that sense, we are controlling for many of those things automatically by defining our controls right? So in general, same population at risk. But we were really worried that places residence, even in the catchment area of the clinics, the COVID was not uniformly distributed. So once we are thinking about case control study, the next consideration is whether we should be matching our patient controls to our patient cases or not. And for matching, so they should always be matched in general, like same kind of population, right? So we already had them matching based on during the same time could have had COVID, and they're both breast cancer patients. But it's often one wants to consider, should we match actually on individual level? So for each case, their own controls. So, and once you start thinking about them, there are a lot of additional issues, like should we match at all, right? So if you ask what characteristics to match on, how many controls per case? If you have many possible cases, how do you select controls? Can controls be used? Meaning, can the same individual be a control for the same case? For multiple cases, right? So one control for multiple cases. Can you have a future case to serve as a control before they become a case? So I'll talk about some of these issues as we go along. So for matching, so to decide whether to match, I think the basic guideline is think about, are there any variables that you really want to match on? And if there are, match. If there are not, do not match. In practice, I don't think I've ever seen an unmatched case control study, I have to say. So because usually you find some good reasons to match up, but it's not like a requirement. So what kind of variables you want to match on? So you want to match on a highly predictive risk factors that you know about, but that you are not interested in. So in our cases, we had like all these COVID potential risk factors, which we didn't really care about. We wanted to do cancer specific, not what increases the risk of COVID in the general population. On the other hand, you do not want to match on characteristics that you want to evaluate as a risk factor, because once you match on something, you adjust it the way it's a fact. So that's a good thing. On the other hand, you will never know whether it was a risk factor or not. So that's why it's important, these predictive risk factors that are not of interest, that's the one you want to match on. It's good to match on complicated adjustment variables. So that's for statisticians among us, it's like variables that you would not want to be including in your statistical adjustment models that make you kind of worry about how am I going to do all of that. So these often are geographical variables or detailed disease types. So this would be like categorical covariates with many, many levels. So in our case, it was a geographical, like where the patient lives potentially. Time varying covariates are very difficult to include in adjustment model. They are much easier to include with matching. On the other hand, you also do not want to match on anything that is, you do not want to, things that you do not want to adjust on. And one example would be intermediate outcomes on the causal pathway. So if you think that the reason some of the cancer characteristics would increase somebody COVID risk because it results in depressed immune system, you do not want to match on an immune system status, because then you lose the effect of the whatever variable you're interested in. You might very well want to collect this information and then maybe do some kind of mediation of analysis to evaluate whether it's on the causal pathway, and that's the mechanism for it, but you certainly do not want to match on it, right? Because once you match on it, you took away that pathway, causal pathway, and that's you don't want to do. And also you don't want to have too many variables to match on. And the problem is with the definition of too many variables is once you can't find matches for your cases. So depending on the number of available controls, it is, too many varies. You could actually match on quite a lot of variables if you have a lot of potential controls and you can find matches for all of your cases. But in practice, it is possible to run into issues with this, especially if you have some detailed variables with many, many possible levels. So how many controls should we be selecting? In general, more controls increases the power. So the more, the better. On the other hand, there are diminishing returns after maybe 1 to 3, 1 to 4. Usually that's what's kind of considered good. So here it comes, the cost consideration comes in. So how expensive is it to collect all the data? Is the data just out there and you just can pull it in? Or do you have to spend a lot of money to get it, or time? And then it is definitely would go on the lower side. There is no requirement at all so that the number of matches to be the same for every subject. So it makes the statistics, especially descriptive statistics, a little bit trickier, but all the analysis, everything else works just fine if you have variable number of controls per case. So that is not a problem. But the usual, of course, if you have fewer for some cases, you are losing some power, but that is not an issue by itself. If you have many possible controls that you could match, then in general, it doesn't really matter too much how you've selected. So random selection is fine. I like actually the best matches. And by this, I mean that I'll say among all the possible controls, I'll take the 5 with the closest age, say, whatever it means to me to be the best in the given case. I like it because it sounds less random. So like it's more well-defined, but of course it's random because my sample is a random sample from the population and so on. So it's not like really, but somewhat the apparent randomness is decreased. In some contexts, if you really have to go out and recruit controls and not looking at existing data, often it's like convenience matches, whoever you can find who matches, right? So then it's even less well-defined in terms of who it is. Whether it's random selection, you don't have the luxury of listing all potential controls and randomly selecting. The issue of reusing controls, right? So the same control to multiple cases actually has no general consensus, but I personally recommend and usually do allowing reuse the controls. So, and I do that because I think conceptually each case defines a population of appropriate controls. Who would be the world of appropriate controls? And we want to select from that. Well, I mean, it can happen that two cases have overlapping populations. For example, because they have the same characteristics themselves, they match each other, right? So then they would actually have exactly the same population. So why do we have to say that they cannot have the same controls? The other issue that can happen if you are not reusing, there are situations in which order of selection. So you first select for this case, then remove the controls from the pool. And for the second case, you have a somewhat smaller pool, right? Because you already removed some of the potential controls because you don't want to reuse them. Then this can result in selection bias, especially if there are timing things are involved. So you have to be a little bit careful potentially with that. On the other hand, if you are reusing, then all the analysis have to take that into account, and they have to be a conditional analysis. So I show an example, but yeah, so then the analysis absolutely has to take into account the fact that you are conditioning on the matching, and because otherwise it's wrong, because you're using the same person twice. So going back to our COVID study, so we decided to do a match study, matched 1 to 3 on what we considered to be non-risk factors, which was age. We matched by over 60, under 60, race, minority versus not, obesity, presence of diabetes. So that was the comorbidities. And for place of residence, we played a lot with it, but we wound up that Milwaukee County had a much higher rate of infections compared to the more rural areas, remote areas. So we were Milwaukee County versus the rest. But again, we are still somewhat geographically constrained because these are all Freighter and MCW clinic patients. And we also somewhat matched on time. You had to have no COVID infection by the time of the case's COVID diagnosis. And we definitely allowed controls assigned to several patients. So the result was we had 25 cases. We have over 300 potential controls, and we were able to define 3 controls for each case, but it actually resulted, there were only 44 unique control patients. So there was actually a lot of reuse. This is probably more than is typical, I would say. So some descriptive. So we have 25 cases, 75 controls. So for example, here is BMI, and we have 25% of people with BMI more than 30 were cases, and 75% were controls. So these percentages are raw percentages, because it's very important for case control studies to keep in mind that the case control status is the outcome. So even though the inclusion was based, they were the inclusion criteria, but the case control is the event, right? And all these risk factors are before the event. So the case control status is the outcome. So that's why I'm presenting the proportion of the outcome. And the fact that BMI more than 30 is exactly the same proportion as the cases and controls, that's not an accident. And that's because we matched on it, right? So this is kind of like just demonstration that we match. So it's exactly the same number, 25% cases, and it has to be like this if we match. But some of the other variables we didn't match on. And again, the way you can kind of decide that a variable seems to be associated is, in general, 25%. In whatever risk factors, you should see 25% of the cases. So if the percentage is not 25%, that means that this is something unusual. And I think the one that here most stands out is whether a patient ever was treated with chemotherapy. And because among people who were treated with chemotherapy, 41% were cases. So the cases were overrepresented in that risk group, right? So that means that this might be unusual. If it would be unusually low, then it would be a protective factor. So, but this is just like general descriptives. If we actually want to analyze the data, we have to do more calculations. So again, for the analysis, it's very important that the case control status is the outcome. Again, since that was the inclusion criterion, it kind of keeps wanting to use it as a predictor, but it is not, it is the outcome. And other important things to keep in mind that the probability that the event will happen, right, in this case, COVID, cannot be estimated from this data. So you cannot estimate the incidence of COVID in breast cancer patients in this data, or the risk of COVID. And that's because the observed risk, the observed probability is set by design, right? We had a 1-to-3 ratio, so it means 25% will be cases, right? So 25% of patients in our study had COVID. We don't mean to imply by that that 25% of all breast cancer patients during this period would have COVID, right? They didn't. It was really, we didn't try to estimate that. We really just, it's 25% because we made it so. And as a result, you cannot actually do many calculations with it. So you cannot calculate the risk ratio, the ratio of the probabilities there. But it turns out that you actually can calculate an odds ratio. So, and this is kind of math magic. So if you write down like the formula for the odds ratio in this case, then there are some things that you don't know, but they happen to cancel out. So even though you cannot calculate the probability or the risk ratio or the risk difference or whatever, lots of other things you cannot calculate, actually you can calculate correctly the odds ratio. So anytime there is a case control study, it has to use odds ratios because that's the only thing that's estimable in them. The good thing about it that usually we do it for rare events, and then odds ratio is pretty much the same as the risk ratio in the big population. That's true for rare events. But the observed risk ratio has nothing to do with the risk ratio in the population. But the observed odds ratio is kind of correct. It is a strange thing, but it works out, luckily. So that's why we always have to use pretty much logistic regression, because logistic regression models odds ratios, and specifically conditional logistic regression if there was a match design. So most often it's analyzed with conditional logistic regression or other conditional logistic kind of analysis. So for our example, this is such a nice example because everything is matched 1-to-3 exactly. So I can work through a little bit of just give you ideas where the numbers will come from. So it's a match set data, and we'll have to again analyze it to incorporated matching, especially because we multiply selected controls, reuse them. So if you so first, if we only had one control, if it's just 1-to-1 matching, so then the way you analyze match sets with 1-to-1 matching is that you have to set it up for each pair, whether the case of the pair had the risk factor or no, and the control had the risk factor or no. So here the risk factor I'm going to analyze is the ever chemo variable that looked most different between the groups. So this means that this should add up to 25, hopefully. Yes, because there were 25 case control pairs, 25 cases, and if I just take one control per case, then it's 25 controls. And there were 8 pairs where both of them had chemo, 1 pair where neither of them, and 5 where the control had chemo, case did not, and 11 when the case had and control did not. And this, so if you set it up, then the informative cells are the one where the result is different. Then that tells you something about the discordant cases. That tells you something about which is more how the risk is distributed. And the odds ratio can actually be calculated 11 to 5, the ratio of those 2 numbers. And if I have, since I have actually more controls, control number 2, control number 3, I can do that same table for each control, get an odds ratio, but since the controls are actually sorted in some random order, there's no actual order between the controls. I'm just call them 1, 2, 3 in random order. These numbers by themselves are not very meaningful, but I could get an overall ratio, and essentially it would add up the numerators, 11 plus 14 plus 14, add up the denominators, so all the green numbers over all the red numbers, and this is the odds ratio 4.3. This is like the overall odds ratio called the Mantel-Hansel odds ratio that's designed for this kind of settings. And it's pretty much the same as conditional logistic regression in this case. And it's 4.3, so we can get a confidence interval. So we can say that the odds of, we can say that odds of getting COVID is 4 times higher if a patient ever had chemo than a patient who hasn't had chemo, a breast cancer patient. So this is kind of the conclusion we can make from this. So definitely having had chemotherapy seems to be increasing. And interesting, like the radiation therapy didn't look like that. And so other kind of therapy didn't. It was really chemotherapy that was associated with an increased risk. What other things we can evaluate in this study? For example, as I mentioned before, we cannot evaluate the effect of obesity, BMI more than 30, because we matched on it. If we were to try to make a table like that before, if we try to make a table like this for obesity, all these red and blue green numbers would be zeros, because there are no occasions where the case is obese and the control is not obese, or vice versa, because we made sure that they're matched on that. And we would get our odds ratio 0 over 0. So we cannot just estimate that. But we can evaluate whether the effect of chemo depends on obesity. So we can incorporate obesity into our analysis, just not to evaluate its risk. So because we could look at the subset of patients, case control pairs, right? Or actual groups, sets, where everybody is under BMI less than 30, and we can have the odds ratio on that subset. And we can have other subset of our matched groups where the BMI, everybody's BMI is above 30, and we can calculate there. And then we can do the hypothesis test whether they are equal. So we don't have a lot of power for it because it's an interaction test and we have only 25 cases, but we can, in principle, this is just to show that we can, in principle, evaluate things like that. So while if we have a variable that we match on, we cannot evaluate as a risk factor, but we can evaluate it as a modifier, right? So whether the effect of our actual risk factor of interest that we did not match on, whether that is modified by the thing that we matched on. So another example of a case control study that we did a while ago with Dr. Zoso from emergency medicine was studying ondansetron. And this is a widely used anti-nausea drug. You might have heard the brand name is, I think, Zofran. So Dr. Zoso told me that they hand it out like candy in the hospital. I assume she was exaggerating, but apparently it is widely used. And it belongs to a class of drugs that's so-called QT prolonging drugs. And QT is a feature of the EKG, the QT interval. So this is, I'm sure you've seen this kind of EKG waves. And the QT interval is the distance between the start of the peak to the end of the T wave. And if somebody has long QT, then this interval you can see is longer. And that is a risk factor for cardiac arrhythmias. So that means that the heart is not beating quite, the electrical conduction in the heart is not quite like it should be. It's a risk factor for arrhythmias, and that's a risk factor for actual cardiac events like heart attacks or something like that. So the question she wanted to answer, so it's so widely used, and even though it's QT prolonging, so does actually it increase the risk of actual cardiac events? So the life to the path to actual cardiac events is long. So just because the QT is prolonged doesn't mean somebody will have a heart attack or something like that. But it does increase the risk. So she wanted to look at that. And so the outcome, the way we defined cardiac events, was actually if they needed CPR in the hospital. So that's, clearly something is going badly if somebody needs CPR. So the hypothesis that she wanted to study is that ondansetron increases the risk of CPR within 24 hours of administration. And the 24 hours is about 6 half-lives. So by that time, the ondansetron should be gone. In the actual study, we did look at multiple time intervals just to see how it changes, but I'm simplifying here a bit. So the population would be adults admitted for inpatient care. And we excluded patients who were admitted in cardiac arrest because it's probably not ondansetron that did that. So the cohort specifically will be all these patients admitted to Freighter between 2010 and 2013. So again, we did that study, it's a while ago, so that's why the data is kind of old. So then what we would want to do is collect information, well, either from chart review, but here we actually use CRDW, the Research Data Warehouse. This was actually one of the very first projects in the CRDW that was relatively newly available. So we actually had lots of data already in electronic form available. So the information we looked at is the demographics, the admission diagnosis, because it's clear that even if ondansetron increases the risk of CPR of a cardiac event, it's probably not the major driver of cardiac events, right? There are lots of things that you would think affect, event risk of CPR, and ondansetron is a small contributor, if any, right? So definitely wanted to know what's actually wrong with the patients. So diagnosis was very important. And then we would need the information on when patients were administered ondansetron, and that's in the pharma records in CRDW, and probably also other QT prolonging drugs, because there are loads of them. And it was actually quite a lot of work to get a list and match them up and everything, but it's possible. And then we also CPR events, and to know when patients are discharged, those are their at-risk period, because you won't have a heart attack in the hospital after you're discharged, because that will not be in the database as linked to the same admission. So this is a case where we really have all the data in the CRDW, but even then, one's trying to think about how to analyze it, as in a retrospective cohort study, because I can define the cohort, all the data, it's there. Some of these things make me think like, oh my gosh, how am I going to adjust for all the possible diagnoses that are out there? How am I going to include the time-dependent process of all these drug administrations? And just like, it sounds really scary. This is like the difficult to adjust covariate. I really don't want to do that. Like, it will be a very complicated model, and whoever will believe whatever comes out of it. So instead, we started thinking about doing a case control study. So what would be the cases? Adult patients admitted to Freighter, right, with the CPR code. That's easy. And the controls will be the same kind of patients without the CPR code. And I have a little start there because we will come back to this definition. And then what is the risk factor that you want to study? Well, it is ondansetron administered within 24 hours before CPR. Right, that's because we are saying that did they have ondansetron, right, during this time period, because we think that's when ondansetron increases the risk. But how do we define it to a control? Like 24 hours before they didn't have CPR? Like that's most of the time they didn't have CPR, right? And even the cases most of the time didn't have CPR. So this kind of definition, it tells us that we will need matching. This is exactly very nice example of when matching is absolutely helpful, because how would you do an unmatched case control study when you don't know which 24-hour period to look at? Okay, so let's talk a little bit about matching with time dimension. So here I have some patients, their time periods. We start the risk period and then we follow up for some time, and then we lose them because they are discharged from the hospital, whatever, we don't have more information. And some of these people had events, right? The red star and the green star are the events, so they are the CPR events. So how do we figure out who is the potential control for say, the red patient? So these are the two are cases, the ones with the stars are the cases. Well, so they would have to be like this person first control. He doesn't have an event, but it wasn't really followed all that long. So maybe, right, they would have had events sooner or later at some time. It's just like they had such a short follow-up, they didn't have time yet to develop the event. So it seems like this shouldn't be a good control. Imagine that this error is like really, really short. Of course, they didn't have an event, there was no time. So the idea is that we would want to match with two patients who are at risk without an event when the case has the event. So for this red star, the potential controls are all patients who are still at risk but haven't had an event yet or never will. So this person, for example, is not a potential control because they are not at risk. But note that this person is a potential control even though they'll have an event later. So at this point, this patient looks just like, patient number 5 looks just like patient number 4, right? Kind of when matching, we have to pretend that we cannot look into the future, because the fact that they'll have an event later on is looking into the future. In fact, maybe this second patient also will have an event right here. We just don't know about it. So how can we tell that, that this is patient at this point? We cannot tell whether this patient is like gonna have an event or is it patient type 2 who will not have an event. And then for this patient, when they become a case, this is the only potential control because nobody was followed up as long. So the better definition for our controls would be all adult patients admitted to Freighter who were in hospital without a CPR code by the time of the CPR of the matching case. Right? So it's not just patients who didn't have CPR, but who stayed long enough in the hospital and say weren't discharged the next day, so to have a chance to have a CPR, right? By the time of the case, because if the case would have discharged 2 days earlier, they wouldn't have CPR either in hospital during that admission. But they haven't had CPR yet. So then the next question, how do we define the ondansetron risk factor for the controls? So once we are matching, it's kind of relatively easy, because again, here is our case, their CPR time, and we have the exposure window, the 24 hours, and then we want to check whether they had ondansetron during that time. And here are our potential controls. Well, we can just take the CPR time of the case, and look at the 24-hour period, the same exposure window in the controls. And note that the first one is not even a potential control because they were not in the hospital during the time of the CPR, right? So we already excluded them in the previous slide, really. So again, so our predictor would be in controls is the 24-hour window before the CPR time of the case. And so then we can compare, did they get ondansetron? Did they get ondansetron? And whether that predicts whether they're a case or control. And in this case, we wound up identifying 250 CPR events. We had 230 cases with control. We also matched by admission diagnosis, which was a really complicated categorical variable with lots of levels. And we also matched by date of admission, so they're kind of same time frame. And we selected up to 5 controls randomly. So here we wound up, since we couldn't always select 5 control, actually not 20 to 80%, but 18 to 82% if you just look at basic district statistics. So anything that's more than 18% or less is potential risk factor. So age, here there just means surprisingly was not a predictor. I thought it would have, but apparently after controlling for admission diagnosis, age was not a predictor of CPR. Gender was not really male, didn't really have more. But ondansetron, right, shows up 27% time, which is much higher than 18. And actually other QT prolonging drugs, 23% versus 18. So they are higher, appear to be higher, though it's not p-values yet. And here it was a complicated enough case with other covariates that we didn't match on. So we just included everything in the logistic regression model, and even adjusting for other things. The big risk factors actually turned out to be race, ethnicity, which we might have matched on, but we didn't. But ondansetron and other QT prolonged drugs, both of them were increasing the risk of CPR. So the conclusion was kind of like, yeah, I mean, it's probably a small effect because these were rare, right? We had like 250 cases in 4 years of freight earth admissions, so it's not like a common thing, but it is a QT prolonging drug, and it does potentially, at least based on this analysis, increases the risk of cardiac events, along with every other QT prolonging drug there is. So, because there are lots of them. So in summary, what's a case control study, right? It's a retrospective design evaluating risk factors. That's essentially its point. The case control inclusion is based on the outcome. That's what makes them weird. It's like a reverse causal direction. It is a nice alternative for a retrospective cohort study when a retrospective cohort study is not really feasible for some reason. Either it's difficult to find a cohort, or you have a rare event and have a risk factor that you're interested in that's expensive to collect. Or there are complicated adjustment covariates like geographics or time or something like that. In the ondansetron studies, so it's much more easier to just define the exposure window instead of trying to figure out all the ondansetron administrations over time or the diagnosis. But it has limitations. It cannot estimate the incidence of the event, right? It only can define whether the risk factor affects. It cannot tell you what's the risk. And you can have study multiple potential risk factors, but only one outcome. In the retrospective cohort study of atresia, we could have multiple risk factors and multiple outcomes associated with the same condition. Here, once we select cases and controls and match them, there is only one outcome you can study with this. And the other last thing is that this study shouldn't be confused with matched potential two group studies, where we still call them cases and controls, but they are not the outcomes, but the predictor. So if you say you want to compare whether diabetes increases the risk of something, and then you collect patients, recruit patients with and without diabetes, and maybe you even match them, and maybe you don't, but that's the predictor. Then that's not a case control study, even though sometimes the words case and control are used. And many of the matching considerations, if you're doing a match study, apply, but you would matching on all risk factors, while in the case control study, you definitely do not match on risk factors that you want to study. So there are some parallels, but it's, even though the wording is similar, it's a very different design conceptually. Okay, I'm sorry, I see I ran over time a little bit, but I'm happy to, if anybody has questions, to answer questions. I see, Marsha, I see you're talking about, you're muted. And I see there's something in the chat. Okay, let me see.
Okay.
Okay.
I have a question when it's my turn.
Go ahead.
So I found it very interesting that that we can use the same control more than once.
Yes.
So maybe I missed the part where you're talking about power. How does that affect the power if you use a control more than once?
It shouldn't affect the power.
Should not. Okay.
No. Yeah. So because it's the number of cases that will affect and the matching ratio. So how many case control matched pairs are there? And just because in two pairs, so it's like the number of, if you imagine each case and each control, and if they match, you connect them with an edge. It's the number of edges that matter. And just because some of the edges goes to the same control, it's not a problem. But again, I have to say that there might be people who disagree with me. So there is some controversy about this thing.
Okay.
So, but I think it is conceptually correct. It just, you have to take into account during the analysis. In some sense, you can think of so very often you have multiple controls, reuse of controls when the cases match each other. Okay, by the things you said, they match. So you can think of it as you are creating, so there are two cases and maybe three controls in one overall matched groups. So instead of thinking about that these case matches three controls and the different case matches the same three controls, you can think all 5 of them are a big match set, and mathematically it's actually equivalent. Then maybe it would be, but if you were randomly selecting or something, you had a bigger choice of selection, you might be just like overlap of 1, because maybe these two cases match 10 potential control, but you pick the one with closest to the age and there's just 1 overlap or whatever. You could have weird results, but it should not affect the power.
Okay, thank you.
Rachel, I see a question where you can watch it back on. I think we try to post this on the BERD website, on the CTSI BERD website.
Which website?
At CTSI, the BERD has a BERD, the Biostatistics Epidemiology Research Design Unit, BERD, has a website, and we will post it there, or the link.
Okay.
Any other questions?
Hi, Aniko, this is Yan. Thank you for giving a nice talk. Specifically, I have a current manuscript question for case control study. So usually, based on experience, under which condition we may think, okay, this control is matched to the case. In our project now, I think the team are try our best to find the perfect control which is corresponding to the case. But we also have a problem because the data is from the hospital patient data. That's why sometimes it could be very difficult to match like age or other status. And the reviewer for this manuscript gave some question like, we can do propensity score. I have the data, but I'm not quite sure whether propensity. I can try to do the propensity score to see whether the match could be better, but I'm not sure how bad can it be. In your experience, how should deal with us?
So I think if propensity score is an consideration, you might be actually in this setting, the match two group study setting, right? That your cases and controls are actually not the outcomes, but the predictor is the risk factor. So that is a little bit different than this, where again, the case control study, that's the outcome. But in general, when matching, right, so you can always try to do use statistics to adjust for things, right? So the whole point of matching is really to not have to do statistical modeling for adjust for the covariate, right? So the kind of things that I want to match on are risk factors that, so, you know, they're so predictive that they can wash out the effect of my variable that I'm actually interested in. Or it's just such a complicated variable that I don't want to adjust for it because I'm dreading the statistical complications. But age, I can just model it, right? Or something like that. So simple things that you can model, you don't have to adjust.
I don't know, because they have like a primary variable of interest. That's their finding. The outcome is like a binary variable. And the reviewer of the manuscript said, okay, because the other covariates like age or other medical history is so unbalanced between the case group and the control group. That's why they think propensity score may help with us to balance the other covariates beside. It
could. So again, there are many approaches to this. Matching sometimes, again, so there are many cases when you actually want to use statistical adjustment as opposed to matching as adjustment. But I think you also can do both. Like on some variables you match, on others you do statistics.
You mean if I, for instance, do you mean I can do propensity score matching certain variables, then put the other unmatched variable as covariates in the model?
Yes.
Oh.
You can do it both ways. So you can kind of combine the two things. Yeah.
Okay, I will try that. Thank you so much.
Any other questions? I know people have to leave because I'm running.
This is Marcia. I have an administrative question. How do I find out if my department has a contract with, is it BERD or?
I think the departments that the Biostatistics Consulting Service. So everybody, the BERD is for everyone. The mini grants.
Okay.
All CTSI investigators. I have to take it back, not for everyone.
Okay.
All CTIS investigators, but it's not a department related thing. For the Biostatistics Consulting Service, we do provide data analysis also issues, services. These are the departments. I think if you're not listed, then you're not eligible.
Okay.
There are other departments have their own access to other statistical services, but neurology, I'm not aware of having any such kind of things.
Okay, thank you.
Well, then, if there are no more questions, I'll stop the recording.